Okay, well, thank you all for joining us this morning on Fixing the Tilt, the Sources and Treatment of Ocular Torsion. This is the APOS 11th Annual Kushner webinar. First, I want to introduce Bert Kushner, the host of this. He's, of course, a professor emeritus in the Department of Ophthalmology at the University of Wisconsin, past president and past program secretary of APOS, editor-in-chief of Journal of Pediatric Ophthalmology. He's the co-editor, or was the co-editor of Binocular Vision and Ocular Motility, and the chief of the Pediatric Ophthalmology and JAPOS journals. He's authored over 200 peer-reviewed manuscripts, 43 textbook chapters. He's edited 3 textbooks and is the sole author of 2 textbooks. He's had numerous named lectures and awards, the Heat Award, the Bressler Tribe. He is one of the 20 most innovative pediatric surgeons alive, according to the top masters in healthcare. And he's done 35 papers on torsion and more. He's really the ultimate mentor for all of us. He's a brilliant thinker, always intellectually honest, curious about the way things work. He can articulate a problem. He can almost always solve it. He has an open mind and an open heart, and he truly is the king of strabismus, a photo taken from an old squint meeting. And with no more ado, let's go on to the webinar today. The goal today is to talk about the causes of torsion, how to measure, and how to treat it. I'm Linda Daghi. I'll be talking about mechanical and innervational torsion, how to think about what you see. We'll have Rosario Gomez de Liano speaking about objective and subjective torsion, the information you need to determine treatment. David Hunter will be speaking about surgical techniques to reduce torsion, what to consider and what to avoid. And Jonathan Holmes will be joining us to talk about a few degrees of torsion, when it matters, and how to treat this small but significant problem. And thank you once again for sharing your Sunday morning with those of us who love to think about torsion. So let's get going. I'd like to show you this picture. It's from a Brooklyn-based photographer, Romain Laurent, who did a whole photographic series called The Tilt Project. Its first showing was in 2009 in Brooklyn. And this gives you a sense of what our patients have to live with, life when the visual world is tilted. Why do tilt and torsion matter? Well, first of all, it's pretty frightening and foreign to all of us. The presence of a tilted image from either eye threatens fusion. There's visual discomfort and asthenopia. Stay out of trouble. Consider it when planning surgery, even if your patient is asymptomatic, make sure you check for it. The sources can be mechanical and innervational, and consider it in your surgical plan. Decide if it's an important consideration and pay attention. So there's 2 kinds of torsion. There's subjective torsion, and this is most common with new onset strabismus, and therefore more common in adults. There's also anatomical torsion, and this may accompany subjective torsion, but without subjective torsion is typical with childhood or long-standing strabismus. It's kind of the torsion or tilt you see at the back of the eye with a patient without torsional diplopia. However, beware. Patients with long-standing strabismus and high-grade stereo and anatomic torsion can develop torsional diplopia after surgery. For example, those patients who develop torsional diplopia after treatment of Brown syndrome, or after superior oblique weakening in a patient with an A pattern and high-grade stereo. So if patients have high-grade stereo, even if their strabismus is long-standing, you can induce torsion. Most patients confuse about 7 degrees of cyclotorsional disparity, so you have a little bit of a freeze zone. And tests like the double max rod and the Lancaster red-green are dissociative. They measure the torsion, which may not be symptomatic, but they can help guide surgical planning. You can find out how much torsion is inherent in that patient's visual motor system. Let's talk about the types of torsion. We have mechanical torsion from infancy. This can come from orbital deformities, as we see with craniofacial patients, where they can have anatomically excyclorotated muscles and hypoplastic or absent superior obliques. You can see it in Brown syndrome, where the severity and the time course help guide treatment. You can have mechanical torsion that's acquired, for example, after orbital trauma, such as dissociated extraocular muscles or restricted extraocular muscles from trauma, from blowout fractures. You can see it in thyroid eye disease, for example, with the tight inferior rectus, and that can be unilateral or bilateral. And the torsion you see from that might be balanced by a tight superior rectus or superior oblique, which will reverse the torsional pattern. You can see it iatrogenically after periocular anesthesia, with buckles, tube shunts, after transposition procedures, and after orbital surgery as above. You can also have innervational torsion and torsional diplopia, for example, from superior oblique palsies that are primary or acquired, with skewed deviation, and with partial more than complete third nerve palsies. So let's start at the beginning. Mechanical torsion from infancy. Let's start talking about orbital deformities with craniofacial patients. So here's a typical child with asymmetric bony development from unicoronal synostosis. You have the harlequin deformity. The harlequin deformity gives you an elevated superior orbital rim on the right, as seen with this patient, which gives retrusion of the superior orbital rim from this disorder. What happens is the superior orbital rim pushes back on the trochlear region and the superior oblique becomes more lax. So in a classic UCS patient with retained stereopsis and uniocular torticollis, you can have a harlequin deformity. And in this particular patient, at age 2.5, he had significant inferior oblique overaction, superior oblique underaction with a 30-degree head tilt for fusion, severe ocular torticollis, inferior oblique myectomy followed by a large superior oblique tuck 6 months later, resolved the torsion and the ocular torticollis, maintaining excellent stereo. In contrast, here's an APER patient with a classic exaggerated V pattern from bicoronal synostosis with this syndrome. This patient was absent fusion. He had significant hyperelevation in adduction, as you can see over here, and under depression and adduction on both sides. Intraoperative findings were those of an impalpable superior oblique on both sides, which you can see on the imaging, hard to see, excyclo-rotated muscles. So in his case, without fusion, inferior oblique myectomies, and inferior transposition of the medial rectus and medial transposition of the superior rectus will help align the eyes. But this directional movement is adverse for a patient who can fuse and will give them diplopia. In this patient, no diplopia, he has no fusion. And you can see the alignment was much improved, but when you look at the back of the eyes, pre-op and post-op, top is pre-op, bottom is post-op, you still have extreme severe anatomical torsion. How about Brown syndrome? You might see encyclotorsion with overaction of the superior oblique in some cases. Well, then the question is, how can you decrease the likelihood of superior oblique palsy after surgical intervention? Because you are weakening the superior oblique with almost every procedure we choose for Brown syndrome. So we took a look at this. In this patient, he had a notable overaction of the superior oblique and hypotropia and adduction, which you can see here. You can see the very large preoperative chin-up posture. And here he is post a superior oblique tenotomy with a spacer, torticollis resolved, and good retained superior oblique function, but not all these patients will retain their superior oblique function. So we did a study looking at this, and in Brown's patients, we found with more than 16 prism diopters of hypotropia in the affected side gaze, as that eye looks towards the nose, you have an 80% chance of avoiding superior oblique palsy. And so I rarely do a procedure on these patients if they don't have at least that degree of hypotropia in side gaze, because over time, the superior oblique palsy will give them diplopia in reading position. So what about acquired mechanical torsion? You have orbital trauma, thyroid eye disease, and iatrogenic causes. So let's take a look at orbital trauma for a moment. In orbital trauma, you could have entrapped or ruptured muscles as a result of the trauma or as a result of the repair with iatrogenic problems. The inferior rectus for sure is the most commonly involved, and it's an excyclotortor. So in this most typical case, classic blow-off fracture of the right eye, and we saw her after disentrapment of the inferior rectus on the right. She had limited elevation, worse with up gaze. As you can see here, her right hypo of about 16 prism diopters, worse as she looks up, worse up gaze to the right, as the inferior rectus works more in the abducted position in terms of its vertical alignment, and 10 degrees of excyclotorsion, pretty classic because it is an excyclorotator. And she did fine with resolution of diplopia and regaining her excellent stereo after an inferior rectus recession on that side, balanced with a contralateral inferior oblique myectomy, so as not to have to recess the inferior rectus overly, and a contralateral recess resect for the inferior rectus on the left to avoid diplopia and down gaze, and she was left without torsion and diplopia only when looking more than 40 degrees downward. But beware, not all cases of trauma are like this. Here's a 44-year-old lineman hit with a high-speed baseball in the right eye. The CT showed a large depressed fracture of the medial wall and floor of the orbit with loss of the orbital strut, but without extraocular muscle entrapment or diplopia. Notable enophthalmos, but no diplopia. He was left with a large medial orbital and floor defect. So, of course, an orbital repair was done because of his extreme enophthalmos. And the orbital repair elevated and replaced all the accessible tissues, the floor and medial wall fractures. There was placement of a single continuous Med4 Titan orbital wall and floor barrier implant. And force ductions, in fact, were free at the end of the procedure, and the enophthalmos significantly reduced. And here he is. You can see in panel A what he looked like before surgery and this beautiful implant placed to keep the orbital contents within. Typical retrocraniolar approach used to repair many medial floor fractures. However, he woke up with horrific diplopia, severe diplopia and ocular torticollis, a right hypotropy of 10 in primary, increasing significantly in upgaze and upgaze towards the nose, upgaze to the left. Gee, was the inferior rectus scarred to the mid-pore implant? Was restriction worse now that the enophthalmos was relieved? Well, be careful and look more closely, because in this patient, he had developed encyclotorsion, 10 degrees in down gaze and upwards of 20 in up gaze, tremendous encyclotorsion. And in the operative note, it stated that the inferior oblique muscle was carefully identified and then severed from its bony origin to enable placement of this large mid-pore Titan implant. And in fact, this is a common technique done by oculoplastic surgeons. Often there's no secondary byproduct, but sometimes these patients develop an inferior oblique palsy, for which he was treated. He had a right superior oblique recession and a left superior rectus recession to reduce the vertical deviation and extreme encyclotorsion, giving him an expanded field of single binocular vision. So it's not always a restricted inferior rectus. What about other sources of mechanical acquired? How about thyroid eye disease? You can have a tight inferior rectus. It can be balanced by a tight superior rectus or superior oblique, as well as the other muscles that are involved. You can have bilateral inferior rectus recessions, which could cause encyclotorsional diplopia. Many things to worry about with these thyroid patients. So just looking at a couple of examples, here's a more classic thyroid eye disease patient, 30-degree prism diopter hypotropia of her left eye, worse in up gaze, 15 degrees of cyclotorsion and a 25-degree chin-up posture. You can see this left eye just does not go up. Treated with inferior rectus recession, which resolved her hypotropia and reduced her ocular torticollis from 25 to 4 degrees. So a pretty standard classic case. But don't be fooled. Check torsion in all these patients. This patient had a left hypotropia of about 18 prism diopters. However, interestingly enough, it was comitant in all gazes and only 2 degrees of cyclotorsion. That's a warning sign. This patient had restricted elevation of the left eye, as you might imagine, but also restricted infraduction of the right eye. Both the inferior rectus of one eye and the superior rectus of the other were significantly involved. So always at the onset of surgery, besides doing a preoperative sensory motor exam and checking for torsion, you have to do force ductions and test for all of these possibilities. In her case, a right superior rectus recession and a left inferior rectus recession were done to relieve this comitant strabismus and minimal torsion. Let's move on to iatrogenic causes. Those are many. You can have periocular anesthesia from causing diplopia and torsional strabismus, buckles after retinal detachment, tube shunts for glaucoma. You can develop this after transposition surgery or after orbital surgery, as we've just discussed. So what about vertical rectus transposition? Balanced as well as imbalanced vertical rectus transposition can cause torsional diplopia. Superior rectus transpositions to the lateral rectus, for example, for sixth nerve palsy, Duane syndrome, tend to intort the eye, though we study this and they can also extort the eye. In contrast, inferior rectus transpositions to the lateral tend to extort the eye. Balanced transpositions do both, intorsion and extorsion. The concept that a balanced transposition relieves you from the risk of torsional diplopia is a false one. The Shitas are a little more protective from this problem. And I found that adjustable graded augmentation, because we often augment these transpositions, done with iterative checking of mechanically endorsed torsion, can help you stay out of trouble. And let's take a look at this. First of all, you need to understand, what in the world do transpositions do? Transpositions simply change the mechanical tone of the eye, where the eye sits in the orbit. If you transpose a superior rectus or an inferior rectus to the lateral rectus, when the brain tells the eye to abduct and look into the gaze of the lateral rectus, the superior rectus and the inferior rectus are not innervated by that direction. They just they give more tone to the eye in that direction. They do not actively force the eye in that direction. So they're not active in that sense. They're just mechanical. If you transpose the superior rectus to lateral rectus, it can induce torsion, as I'm sure will be discussed later. If you pull that superior rectus down to the lateral, it will try to right itself and bring the eye right back up in the superior direction, causing intorsion. And if you transpose the inferior rectus to the lateral, it can induce excyclotorsion. As this change is purely mechanical, it's not induced by innervation. You can measure this change or the risk of this change during surgery. You can explicitly limit the magnitude of torsional change by choosing the ideal location of posterior fixation sutures. So for example, if you put on several, like at 6, 8, and 10 millimeters back, if by the time you put on the one at 10 millimeters back, there's too much induced torsion, you can simply remove that during surgery and avoid the problem. What about torsional innervation? Superior oblique palsies, primary, early, or decompensated, can cause a problem with this. I'm sorry, are you guys seeing an extra image here? Perhaps not. Or you can have acquired, often mixed with other cranial nerve disorders. You can develop it from skew deviation, or you can develop from third nerve palsy, most relevant when partial. Here's a fourth nerve palsy with compensatory ocular torticollis resolved with monocular occlusion. Here you see a young patient with a left supraoblique palsy and a head tilt to the right, which was sustained as she became an older child. You can see with monocular occlusion, the torticollis is resolved. Here, in contrast, is a 52-year-old grade school teacher, torsional diplopia for 18 years. Symptoms worsen down gaze, primarily when reading. She used to close one eye to read, and over time, she noticed this in primary position as well. So here's her sensory motor exam. You can see that the dysmotility in terms of vertical and horizontal misalignment is really trivial. Her biggest problem is primary position, 18 degrees of excyclotorsion, and in reading position, 23 degrees of excyclotorsion. 3+ fundus excyclotorsion, so severe excyclotorsional diplopia with minimal misalignment. She would read in chin down position, and in spite of all this, had maintained 40 arc seconds of stereo throughout her life. This is a case of bilateral congenital weakness of the encyclotorsional fibers, that compartment of the superior oblique, and I'd love to hear Joe Deemer's thoughts about that particular compartment. You can see her alignment is pretty good in all gazes. The treatment was bilateral modified Hirata Ito's, and this was successful in this case. So the take-home lesson on this is, if you do not mind the torsion, you may miss the opportunity to fix the problem. She certainly looked pretty aligned, but torsion was her big problem. You can have weakness of multiple cranial nerves causing torsional problems. Here's a patient with a paracellular meningioma causing a partial third nerve palsy and subtotal fourth and sixth nerve palsies, headed towards complete ophthalmoplegia, but not there yet. Here he is after ptosis of the left eye is repaired. You can see that that left eye cannot fully abduct because of the significance of the complete sixth nerve on limited elevation and depression. He did have a region of fusion, 30 degrees head turn to left and 10 degrees chin down posture. Vertical and horizontally aligned with 45 prism diopters of base out and 10 base down in the left eye, but the image was severely tilted. So prism certainly was not going to be an option here because he had 20 degrees of excyclotorsion. The severity of his cyclotorsion due to complete fourth nerve palsy and superior rectus function, which was weaker than his inferior oblique and inferior rectus function because of his partial third nerve palsy, gave him severe cyclotorsional diplopia. So in addition to fixing his horizontal and vertical surgery, you would not really fix this problem if you had not fixed his torsion. So he ended up having a modified Harada Ito. But in this case, the Harada Ito was performed on the contralateral eye because he had a complete fourth nerve on the ipsilateral eye. So always remember to consider the contribution and the way the contralateral eye can help you. And this was done to induce encyclotorsion and reverse his excyclotorsion. Patient reported after the tilt is gone. In his sweet spot, he can fuse an up and down gaze and reduce torticollis. So the take-home message from this lecture is never forget to consider the tilt. And even in patients who don't complain of it, see if you can get some double max rod or other form of testing beforehand so you don't end up choosing a procedure that might cause diplopia in a patient with any region of fusion. Once again, thanks to Romain Laurent, the TILT project, for producing these beautiful pictures of what it's like for our patients who experience TILT. And with no further ado, we're going to go on to looking at objective and subjective torsion, information you need to determine treatment. Will be presented by Rosario Gomez de Leano, Professor of Ophthalmology at the Universidad Complutense de Madrid, Chief of Motility Unit at the Hospital Universitario Clínico San Marcos in Madrid, and the past president of the Spanish Strabismological Association and the European Strabismological Association, ISA. Thank you.
Okay, let's share my screen. Okay. Okay, thank you very much, Dr. Kushner and Dr. Daghi, for this very kind invitation. It's really an honor to be here, and I would like to congratulate you, Linda, for this very well-deserved award. I'm going to speak on objective and subjective torsion, the information you need to know. We have seen very good now. Why do we have to know about torsion? And now I would like to concentrate more on how to evaluate this ocular cycloposition. So ocular torsion refers to the rotation of the eye around the visual axis. It's what we call cycloposition. This rotation can be an extorsion when the eye goes towards temporal, and intorsion when it goes towards nasal. We have seen why do we need to evaluate this torsion. When do we do it? In every case that we have diplopia, and I will say it's very nice to have in most of our strabismus, especially if the patient refers the image is tilted or that we have a vertical strabismus. But in cases where we have central pathology, it's also important because it gives us good aspects for differentiating between, for instance, a forenerve and a skew deviation. It will explain us the etiology of the case, but we want also to know how big it is. How do we have this torsion distributed between both eyes? Maybe at the beginning, it was a forenerve palsy of one eye, but with the time, if this eye is fixating, we can see it in the other eye. We want to know which is the impact in the patient and the priority to correct it. There are patients that they have a vertical, a very small torsion that they can fuse, and it's a very different position to work in this case than in another, that the main problem is the cyclotorsion. So it will help us a lot to do our surgical planning. So then how do we do this evaluation? And what I mean, it is important to differentiate between objective torsion, which is the motor position, the anatomical position, and the subjective torsion, which is the torsion that is perceived by the patient, the sensory one. And along the years, there's a lot of publication, and we did some research in both of two. And I would like to give clear clues to differentiate both of them and to see how better to use both of them. What it is important from the beginning is to know that objective torsion and subjective torsion, although they don't follow linear correlation. They play several roles and very often they do not coincide. So the objective torsion, I am going to explain first, even though we use much more our subjective values in the daily life. But I prefer to understand first the anatomical reasons and then to go into functional reasons. So the objective torsion is the relation of the papilla and the fovea. Usually we say that the position of the fovea is the inferior third of the papilla. And along the years, we got different values, but in general, we say that the fovea is located in the inferior third of the optic nerve. But then, in order to be able to calculate values and to do averages and to see pre- and post-operative measurements, we began to analyze what we call the fovea disc angle, which by average today is around 7 degrees. But how accurate and which is the value of those measurements? Along the years, we have studied this objective torsion with different methods. Indirect ophthalmoscopy, that was the beginning, then the retinography, then appeared the OCT devices, and then the wide field cameras. For many years, we've been using indirect ophthalmoscopy, that we have to remember that we have to turn the image 2 times, one upside down and right and to left. It is a very fast clinical information. If you have your patient dilated, you take your indirect ophthalmoscope and very fast you have an information if you have a big or a small torsion. And that is very useful in children that they cannot sit in an OCT, for instance, or in the operating room. But it has some limitations. The minimal detected angle is very large, and the reproducibility for the studies is not as good as we wish unless you are someone that they are very experimented with this technique. Then we want to take some images of our foveal disc angle, and we began with the retinography, which is the classical gold standard. The problem is that we have to export these values, and if the fovea, if we have small pupils, we need to dilatate, and if we have media opacity, the quality of the image is not so good. So in those cases, sometimes we are a little bit more limited. But I have to say that today, the OCT device, they are so close to us that sometimes they are easy to use it because they have sometimes automatic values. For instance, the 4D system of the glaucoma program of the Spectralis give us already a numeric value. And if we analyze the repeatability of these measurements is the highest that we have today. For instance, the minimal detected angle change with Spectralis is only 2 degrees, while with retinography is 4 degrees. But that sometimes for our torsion evaluation is big enough. The problem is when we have highly myopic maculas, for instance, with very bad quality of macula, that maybe the best device that gives us the best measurements is the Cirrus, the cube that we can manually detect the fovea. There are other methods used. For instance, today that we use so often are wide field cameras, and we are documenting our pathology. Sometimes we see very extorted maculas. But this device has its limitations because we have to position the gaze on the side. It's a device that estimates the torsion. And if the head is not very well placed, especially in children, sometimes we may have large torsions that they are not really true torsions. We also have search coil devices that they are complex and they are cost, and also the video oculography devices that for us, to the moment, they're not so precise as the OCT devices. But which is the main objective torsion evaluation, the main limitation? is the human variability, because we can be very precise when we measure these measurements. But we know that the fovea disc angle by average is 7.25. In most studies, the average is between 6 and 7.5. But we know that we have patients that they could even have 13 degrees and they are normals. And that is something that is a limitation for the objective torsion evaluation. But then we have to work with those numbers because they're good enough to evaluate. For instance, one thing that if we see a very large extorsion in one eye and not the other, that's not normal, because the difference between both eyes by average, they're to a max of 1.5 degrees. And if we find 5 degrees of torsion between both, that's not normal. We have to remember the left eye is always more excycloposition. It is important when we want to see these differences between both eyes that the head is well aligned and we don't have a problem in our device alignment, that maybe only 1 or 2 degrees of disalignment may change the difference between right and left. Then, if we have 7.5 degrees, but is a very small child, maybe it is already a torsion. And we have evaluated how the extorsion changed over the years. And that depends on the age, that it increased the ink cycle and the sex. The female have more ink cycle. And of course, it may change if we don't position properly the face, because if we contra-rotate, there are going to be changes in both eyes. Let's go to differentiate now a little bit subjective torsion. Subjective torsion is the perceived torsion, and it is different to objective one, because we have adaptation mechanisms, especially when the torsion problem began very early or when it is long time since the evolution since the onset, or the fixing eye sometimes is the affected eye, and we may see more torsion in the non-dominant eye. And it is also important to see if this torsion is big enough to do an impediment of fusion that, as already Dr. Daggy said, the usual amount is 7 degrees. We may even find some patients that can reach 16 degrees of cyclofusion, but that is rare. How do we measure this subjective torsion? Again, we have different devices that may vary the use along the schools. And all are good, but all have their strengths and their limitation. And we did also some studies on those comparison. How do we proceed when we want to see a subjective torsion? Well, what I always want is to begin with a qualitative, non-dissociative test. For instance, you ask the patient that he shows with the hands how he torts it, or recently Donnie Sue presented or how to control it with 2 Snellen cards and a protractor. I use the vectrographic polarized lenses that they are not very dissociated, and with 2 cards the patient can show me how he tilts one of the image, and maybe with the tilt program you even can calculate how much the patient tilts. That is a very good way to see how the patient perceives this torsion in the daily life, if it is big or it is small, which is the eye that is supporting this torsion, and even you can move a little bit the head up, down, left and side, and see how it changes in different positions of gaze. But then for our calculations, we want to quantify. And the most widely used method is the double Mador-Rod test, because it's very simple, very accessible, very fast. And the problem is it begins to be a little bit, a lot of dissociation it induces. There are many ways to do it. I prefer to begin with red in one eye and white in the other. Sometimes one of the eyes suppressed and we change the 2. And then at the end, you can even put 2 reds in order to see if it's a difference in one on the other eye. The problem of the Mador-Rod test is that if you follow the lines of the glasses, it detects 5 degrees. The minimal detected angle for the studies is 3. You can sometimes even calculate a little bit later with the tilt programs, but it is very variable in quantifications. If you do 2 or 3 times, the patients change a lot, especially elderly, that they don't collaborate so well with this device. The better reproducibility using double Maddox test at the very end is to sum the maximum of both eyes together. I have a Grassi torsionometer that in Europe we use it a lot, and it is a little bit more reliable because we have more amount of gradations. And some use, instead of double Maddox, the Bagolin lenses because they are less dissociative. If we want to do more precise measurements, then we have to use the Synoptophore or the Harms screens. They are very dissociative, they are time-consuming, and they are not available everywhere. Harms is used a lot in Europe, but Synoptophore is used all over the world. The good thing is that they detect very small amounts of degrees, and the repeatability with those tests is very good. The minimal detected angle with those are just 2 degrees. You can see how much is in each eye within a Synoptophore, but with this device, we have to know that we get larger degrees of torsion than with the Maddox. We can evaluate it in primary position, we can evaluate it in different positions of gaze, and the good is also that if we have a patient that with prism, he doesn't fuse, we can see if rotating the slides, we can see if the patient has a cyclofusion capacity with fusion slides, and that is very good for the surgery. Then there are many other methods. You can use your Hess or your Lancaster screen. In Europe, we use a lot the Weiss screen, and you use the left screen torsions. And then you can measure how they tilt. The problem with this test is that you cannot quantify as good as you can quantify the Synoptophore, but it gives you a very good amount of, a very good picture on how the torsion changes in the 9 positions of gaze. And then there are other tests to evaluate, like the Awaya cyclo test that apparently detects only 1 degree of change, but it is sometimes very difficult for the patients to decide between one and another target. And finally, all over the last years, we are beginning to have many digital devices with torsional slides that need more to be evaluated. So in summary, it is important to differentiate and to understand what is torsion and why do you have to evaluate it. It is important to differentiate what it gives the objective and the subjective torsion that may do not consider. We have to evaluate the magnitude, the eye in which is involved, and the fusion capacity as key factors. The objective cycloposition, it is important to know that it is about 7 degrees, but there is a human variability that may change with age, with the gender, with ethnicity. Remember, the left eye is often a little more excyclotorsion. The greater precision is with OCT, and the macular cube is good in case of the poor macular definition. And if you observe in dynamics the cycloposition, you can see small cyclo movements that they are very useful, as Dr. Mike Brodsky pointed out. And finally, we have fundus of ophthalmoscopy that it can give us a very brief check, a very good information. And in terms of subjective torsion, we want to know also how is the magnitude in which eye and how the patient can fuse it. We begin with a qualitative test that is very least dissociative, and then we want to quantify with more precise methods like the Synoptophore. We want to know the fusion capacity. The double rod max is very inexpensive, it's very rapid, but in terms of reproducibility, we have to use the Synoptophore. And with that, I just want to thank you very much for your very kind invitation, and thank you back again, Linda, for your award.
Thank you for that wonderful lecture. I'd like to move on now. Rosario, thank you very much for teaching us about how to evaluate these patients. But now we're going to move on to treatment. We've presented examples, evaluation. Let's talk about surgical techniques to reduce torsion, because that's what we all want to know. What to consider and what to avoid. And with that, I'll turn the floor to David Hunter, ophthalmologist and chief at Boston Children's, professor and vice chair at Harvard Medical School, president of APOS, board member of Rebion, Blink Vision Screener creator, and one of the top 12 innovators in Massachusetts, according to the Boston Globe. With no further ado, I'm going to unshare my screen and move on to Dr. Hunter.
Well, thank you so much for including me in this seminar today, and I've already learned a lot and am looking forward to going on with the discussion. So we have already, as you just said, learned about some of the problems and which patients have problems that need to be addressed, and then how do we measure the problem. So now what do we do to deal with it? None of these financial disclosures are relevant to today's topic. So in terms of, so that we've divided out in what to consider and what to avoid. So for what to consider, we want to think about, do we want to intort the eye or extort the eye? Do we want to do oblique surgery, or can we use a transposition? And then we'll talk about some common procedures. In terms of what to avoid, we'll talk about avoiding over and under corrections. You emphasized how important that is. Avoid making torsion worse. Avoid creating a new torsional problem, and avoid impairing ductions of the eye, which you might not have thought about. So these are the goals in the next few minutes, and we're only going to focus on techniques that strictly address torsion and don't necessarily address eye alignment. To get back to a comment you made about superior rectus transposition causing the eye to intort, actually, in general, the eye will respond to transposition by rotating itself. So if you want to intort the right eye, you're going to move the superior rectus laterally, or actually all the muscles will move in that similar direction to intort the eye. So the eye is going to react in the opposite direction that you move the muscle toward the original muscle insertion. So you would extort the muscle to intort the eye in all four of those cases. So that's how transposition, you can use a transposition to, if you want to intentionally intort the eye, though you don't necessarily get a lot of effect depending on what else you're doing to the muscle at the time. We also think about sort of transposition when we do the mini tenotomies. So if you do a mini tenotomy, that's theoretically a transposition because you're moving, in this case, if that's the right superior rectus muscle, you're moving the insertion laterally. So that would cause a compensatory intorsion of the eye. Although in practice, this appears to have a pretty minimal effect. Something to think about if you want to do a little finesse in your mini tenotomy. So now we'll get to the oblique surgery. So when we're talking about goals, the goal of intorting the eye. So we can either strengthen the anterior third of the superior oblique, or we can weaken the anterior, say, 7/8 of the inferior oblique. So the superior oblique strengthening, we all think of the Harada-Ito procedure. We want to strengthen those anterior fibers of the tension to intort without changing the vertical alignment. So in the original description, it was just split and pulled over and tied 8 millimeters posterior to the lateral rectus insertion. The Fels modification, the tendon is secured more carefully and then attached at that same location, detached and then reattached at this same location. However, in each of these cases, you're also transposing the muscle, and this can sometimes cause, especially in high myopes, an abduction limitation that you didn't really want to get. And so there's been a movement toward getting away from this approach entirely. Jonathan Holmes has lectured on resecting the muscle, and more recently, Eric Bothan and Maud Anderson published this plication approach for tightening those anterior fibers. And so this is what I am doing now. You secure the muscle, the tendon, you split the tendon, you secure it however many millimeters back you want it, and then you placate it. Now, Eric also talked about creating making it adjustable post-operatively, though I find that we really want to tend to want to get about as much as you get. It's very hard to overcorrect these. And so I find that we can usually judge intraoperatively whether we've done enough, and I'll talk about that in a minute. So either plication or resection here, if you don't want to do a plication, either one, adjustable or not adjustable, depending on if you want to do that as well. So then there is inferior oblique surgery, and Bert Kushner talks about the anterior 7/8 disinsertion. The anterior, just like the superior oblique and the inferior oblique, the anterior fibers have more torsional action, and you can get a 3 to 5 degree in torsional shift. And I just have to pause for a minute. You were talking about Dr. Kushner as a mentor for us all. And indeed, I had a case one night and I was puzzling over the case. And then that morning in the shower, I had an epiphany. I know I need to do Bert Kushner's inferior oblique anterior 7/8. I knew he had some surgery on the inferior oblique, couldn't remember what it was. And I hadn't bought his book yet. And so I looked for anything in PubMed, nothing there. So I emailed him that morning. I had surgery was that day, the second case of the day. And before I was done with the first case, he had emailed me back with the chapter accordingly. So thank you, Dr. Kushner, for that. I found the inferior oblique muscle, sling a little suture around it, cut the anterior 7/8, and then you wrap that tied suture around to tidy it all up so that the fibers don't find their way back. So those are all the things we can do to intort the eye. Now we want to talk about how do we extort the eye. So again, the eye is going to respond to a transposition by rotating, and it's going to rotate in the opposite way that you transpose the muscle. So if we want to extort this right eye, we're going to move those muscles in the opposite direction we said before, and then the eye is going to you intort the muscle to extort the eye is one way to think about it. And so then if that's not going to be enough, we can talk about doing either superior oblique or inferior oblique surgery again. So in the superior oblique, now we're going to weaken the anterior 1/3 of fibers. You can either do that nasal or temporal to the superior rectus muscle. Maybe nasal, probably a little stronger effect, maybe. Or there's also been described a reverse Harada Ito by taking those fibers and actually suturing them in place to hold them down. But I think probably just doing a little tonectomy is plenty. So that can extort the eye. And then what about the inferior oblique muscle? Thanks to Jonathan Holmes for pointing out this book chapter by Monty Del Monte, who talks about now we want to advance the anterior fibers of the inferior oblique. That's not anterior enough, I guess. So Del Monte published that method. He said you just take the inferior oblique muscle and you transpose it beneath the lateral rectus muscle and suture it to the sclera at the superior border of the lateral rectus, 8 millimeters posterior to the lateral rectus insertion to follow the path of the muscle. Presumably, you might be able to just do that with the torsional fibers, but no one's ever described that. That's what to consider. So now what about what to avoid? So we want to talk about avoiding inducing torsion when we treat a hypertropia. We want to avoid under and over corrections, avoid limiting horizontal adductions. And I also want to talk about avoiding worsening torsion when you treat A or V patterns, because this can happen. So here's a case where we want to avoid worsening torsion, similar to what Dr. Daghi talked about. 62-year-old man, he's got a comitant right hypertropia, 9 degrees of extorsion on double Maddox rod testing. So he already has extorsion. So what are you going to do? You're going to recess the right superior rectus, or you're going to recess the left inferior rectus? Well, the superior rectus, let's see, that's an intorter. The superiors are in the in crowd. The inferior rectus, that's an extorter. And so if we weaken the inferior rectus muscle, then that will reduce the extorsion versus if you weaken the superior rectus muscle, you're going to increase the extorsion further, and you may put the patient over the line into torsional diplopia. So in this case, you want to do a left inferior rectus recession to reduce the extorsion of the eyes. Now, I mentioned following torsion intraoperatively, and Jonathan Holmes published on this, the Holmes dots. So, because Guyton had taught me to do indirect ophthalmoscopy, which was good, but I think this is a little more precise and more accessible. You simply put a couple of dots on the eye at the beginning of surgery, and then you watch what happens during surgery and see what sort of torsional change you can get. Now, one thing that I do, though, is I was looking for even more precision. So what I do is I borrow a refractive surgery marker from the kit, and I place those marks on the cornea, and then I place you just use some tape above and below the eye, take a ruler to mark the initial torsional position of the eye. Then I do my surgery, whatever I'm doing, and then remeasure. I take that ruler out again and remeasure or reassess and either estimate how much torsion or grab another tool from the refractive surgeons. And you see here we've induced about 10 degrees of torsion with whatever surgery I just did. So next is, again, I just want to get back to avoiding abduction limitation when tightening the superior oblique tendon. If you leave it in its place, then you're not going to create a problem. But if you do, so that should be fine, either plication or resection. But if you do either of the Harada Ito classical techniques, you're going to be repositioning the muscle for no good reason and risking creating a new horizontal problem. So I would avoid that as a practice. And then finally, just want to talk about A and V patterns because fundus torsion matters here. We all, when you have an A pattern, it's because the eye is extorted, generally speaking, because the eye is intorted, and a V pattern, generally speaking, is because the eyes are extorted. And so if the eyes are torted like that, then they're going to follow the A or the V pattern. And so what is what are we told to do if we want to treat the pattern? We're told to follow this, this thing where you move the laterals down or the medials up for an A pattern or the medials down, the laterals up for a V pattern. What does that do to torsion? Not good things. If you move the laterals down, then the eye is going to respond in the opposite direction. The intorsion is going to get worse. Same goes for a V pattern. The extorsion is going to get worse. And so if you have an A or V pattern and you already have the torsion that you expect to see, you really shouldn't be doing these transpositions. You should be doing oblique surgery to treat the patterns. So unless there's no torsion or paradoxical torsion, I would avoid those transpositions. So to review, what to consider. For transpositions, you can extort the muscle to intort the eye and vice versa. For superior oblique, you weaken the anterior or you strengthen the inferior anterior fibers or inferior oblique anterior fibers. To treat extorsion, we strengthen the anterior fibers or weaken the anterior fibers of the inferior oblique. What to avoid? For over and under corrections, use intraoperative marking of torsion. To avoid making torsion worse by selecting the muscle, to avoid creating a new torsional problem by avoiding transpositions for A and V patterns, among other things, and to avoid impairing ductions of the eye by avoiding lateral transposition of the superior oblique muscle. I did long ago, Paul Phillips and I did a chapter for the Rosenbaum-Santiago book. I just checked the QR code. It's not perfect, but you can eventually find the chapter. It's free. It's still out there. It's 20 years old, but torsion hasn't changed too much, at least the evaluation. So thank you all, and thank you for including me. Really happy to be a part of this presentation.
Thank you so much, Dr. Hunter, for that excellent description of the techniques we need to consider when treating torsion. These are critical techniques. And right now, I'm just going to share again and move on to our last speaker, who is Dr. Jonathan Holmes. He's going to be speaking on a few degrees of torsion, when it matters, and how to treat. He's the professor and chair of ophthalmology and visual science at the University of Arizona in Tucson. He's a network leader and has been for decades now, a PDIG, past co-chair, chair, and vice chair, and is really one of the major voices of PDIG. The Joseph E. and Rose Marie Green Professor of Visual Sciences at Mayo Clinic in the past and professor and chair of the Mayo Clinic in the past as well. And with no further ado, let's move on to Jonathan.
Many thanks. So let me get to my first slide here. So I have no financial relationships to disclose other than some funding from the NIH. I'd like to take this opportunity because we've got 250 people who are really interested in strabismus, just to let you all know that the International Strabismological Association is having its every other year meeting this time in Buenos Aires in November, and the website is open and the abstract submission will be open next weekend. So I'd encourage all of you to consider coming to the ISA in November in Buenos Aires. So we've already heard from all our speakers what bothers patients with torsion. Typically it's a torsional, a tilted second image, but they can also present with instability of fusion, an inability or a difficulty comfortably fusing coexistent vertical and horizontal deviations, and blur and reading difficulty. We've talked a little bit about quantifying torsion, but this is going to be important when we're assessing very small amounts. Our go-to is the double Maddox rod, just to remind you that they're typically put in trial frames with increments of 5 degrees, and we have to estimate the 1 degree increments in between those 5 degree amounts. And what the brain sees, and Dr. Gomez de Liano highlighted this, is the net amount, the difference between the two. So if you measure 2 degrees of X cyclo in the right and 3 degrees of X cyclo in the left, then the net is 5 degrees of X cyclo. Whereas if it was 2 degrees of X cyclo in the right and 3 degrees of in cyclo in the left, then the net would be 1 degree of in cyclo, and those are very different. When we make a single measurement of torsion in the office, that's just one estimate of what the patient's true torsion is. And we have to remind ourselves that there is test-retest variability in any biological variable. And so for many years now, I've been making 3 measures of torsion because of this variability to get a better estimate of what the patient's actual torsion is. And I start from scratch on each of those 3 measurements. I set the dials at 45 or 60 degrees, and I ask the patient to make the red line flat, ignoring the white one, and then to make the white one flat or horizontal like train tracks. And then I have a measurement of torsion. And this is the sort of scheme that I create where I make a single measurement, then I repeat it, and then I repeat it again. And so I have 3 net measurements, and then I take the average of those 3 net measurements to get the best estimate of what the patient's true torsion is. And this is particularly important when we're dealing with very small amounts of torsion. Dr. Gomez de Liano has highlighted the problems with the disc foveal angle, the wide range of normals from 0 to 13 degrees. And so if you have a patient with, let's say, 9 degrees of X cyclo, then is that normal or abnormal for that particular patient? Is it problematic or is it trivial? In the world of double Maddox, we have a tighter range of normal from about 2 degrees of in cyclo to 5 degrees of X cyclo. But in the same way, if you have a value that's within the normal range, it could be normal for that patient or it could be abnormal for that patient. And the magnitude of torsion doesn't tell you whether to address that torsion. The way I think about it is the torsion can range from any value. Typically, we don't see values greater than 30 degrees of X cyclo to 30 degrees of in cyclo. And I think of it as there are a small number of values that are almost never associated with a problem, let's say 0 to 2 degrees. But you have a whole range of patients from 3 degrees to 15 degrees where it's sometimes a problem for that particular patient. A patient may have 10 degrees of X cyclo, and that particular patient may fuse that very nicely, or that particular patient may be very symptomatic. That's particularly problematic when we look at these small values of 3 to 5 because it overlaps with the normal range. And so these small values can be normal and asymptomatic for some patients, and they can be problematic for other patients. So the way I think about that is that I go back to evaluating horizontal deviations and I say, well, we all see patients with a 2 prism diopter ESA deviation distance. Some of those patients have a problem and some of those patients have no problem. And how do we distinguish from that? Well, we listen to their symptoms, but we also use horizontal fusional amplitudes and we rely on our orthoptic teams to help us with that. And we ask the question, is this particular patient on the edge? Are they about to break down or not? When we translate that into the torsional world, we have to use a synoptophore. And when you use a synoptophore, you have to specify what type of targets you're going to use. If you use the circle and the cross, or the hot cross bun, as some of us call it, that is a dissociated target. It's very useful for measuring torsion in various positions of gaze, but it will give you a dissociated value, which will be somewhat similar with the double Maddox. I like to use house targets because there are fusional cues and it will measure how much torsion is needed to fuse. And typically you'll get a lower value than with the double Maddox rods. There are two main questions in my mind when you're using a synoptophore. And again, we're relying on our orthoptists to really help us with these tests. And my first question is torsion a barrier to fusion? And the second question is the patient on the edge torsionally? So what do I mean by on the edge? Well, here's an example of a patient who's not on the edge. A patient requires 5 degrees of X cyclo to fuse on the synoptophore, but as you wind the dial back and you get to 0, you can go beyond 0 in this patient. You can get onto the in cyclo side, and this patient is not on the edge. They're not about to break down. Contrast that with this patient who takes 5 degrees of X cyclo to fuse, but as you wind the dial back, and this is analogous to using prisms in horizontal and vertical deviations, you can just get this patient to 0, but then they split and they complain of double vision, and this patient is what I call on the edge. Here's another patient who's even more in trouble because they're worse than on the edge. They need 5 degrees to fuse, but as you wind back towards 0, you can't get them to 0. And so this patient really needs their X cyclo corrected. So let's illustrate these principles with a couple of cases. Here's a 61-year-old female, a diabetic, who has had vertical double vision for 2 years. She comments on the images twisted when it separates, and she was worked up by neuro-ophthalmology, had a negative MRI for the brain and orbits, and was told that she was not a candidate for prism. She has what looks like a pretty classic fourth nerve palsy with a 10 prism diopter right hyper, inferior oblique overaction. She measures 5 degrees of X cyclo on double Maddox rods. I took her to the operating room and I did a recession of the right inferior oblique to Park's point, a typical 10 millimeter recession. And I did that because typically in my hands, an inferior oblique recession will correct anything from 2 prism diopters to 10 prism diopters for hypertropia and will typically correct 5 degrees of X cyclo. And indeed, she did well on post-op day 1. She was happy, her diplopia was resolved, and she only had a 1 prism diopter hyperphoria, and there was a reduction in her X cyclo. But she returned at week 6, and she wasn't so happy. She had a slight recurrence of a hyper at 4 prism diopters, and she had 3 degrees of X cyclo, not back to the original 5, but this was symptomatic for her, and she complained that she could see a twist when the images separated. I did offer her an operation, but she decided she wanted to try Prism first, and she came back 5 months later having tried Prism, but she had almost constant diplopia with or without Prism, and she had a 4 prism diopter right hypertropia, but only measured 2 degrees of X cyclo on double Maddox rod testing. So here she is with residual inferior oblique overaction, much smaller angle vertically, and a much smaller amount of torsion. When we put her on the synoptophore, even though she measured 2 degrees of X cyclo by double Maddox rod, she actually needed 4 degrees of X cyclo on the synoptophore with the house targets to fuse. And as I wound her back towards 0 to see whether or not I could get her into the in-cyclo range, she actually broke immediately at 3 degrees of X cyclo. She broke in the other direction at 8 degrees, showing relatively small cycloflusional ranges, but here not only was torsion a barrier to fusion, but it demonstrated that she needed X cyclo correction to be comfortable. So my go-to for small amounts of torsion and large amounts of torsion is actually the resection and advancement of the anterior third of the superior oblique, and Dr. Hunter has introduced that technique. In this particular patient, I resected at 8 millimeters, and typically I get 1 degree for 1 millimeter if you're on a dose table, and I advanced it to the insertion. I also combined that with an inferior temporal pole recession, inferior rectus temporal pole recession for the hypertropia. And these are a few photographs to show that. I typically approach the superior oblique from the temporal side. So I've isolated the superior rectus, and this is looking up under the lid. I've isolated or demonstrated the whole width of the tendon, and then I've split it for 20 millimeters, splitting the anterior 1/3 from the posterior 2/3, and then I clamp the anterior 1/3 at the insertion. I cut the anterior 1/3 from the insertion, and then I bring it forward, and then I can place my 6 ovicral sutures in a typical double locking fashion at each side, and then I can resect the excess tendon, and then I typically take scleral bites 3 millimeters temporal to the original insertion, and as highlighted by Dr. Hunter, the reason that some of us do it this way is it does not anteriorize the fibers, and so you don't have to worry about inducing an esotropia. This is my pole recession, which is analogous to doing a partial tenotomy, and I do that for small verticals. I monitor this with the dots on the limbus, borrowing the pen from the oculoplastic surgeons. At the time of adjustment in this particular patient, she was overcorrected, and that's what you don't want from a vertical standpoint. And so I advanced the pole of the inferior rectus. But I do want an overcorrection of the encyclo, and I do like to do these on adjustable sutures so I can set them with the desired amount of overcorrection. But I tie these patients off with the encyclo overcorrection. And this is a series of patients that we collected, which demonstrates that these patients do unwind when you do this type of Harada Ito, and so you want to leave them with a small overcorrection. A year later, she was doing extremely well, demonstrating that correcting that very small amount of cyclo deviation was necessary to deal with this patient's symptoms. What was my take home from this particular case? Well, in that particular case, I hadn't assessed the torsional amplitudes at the initial exam. I thought that my standard inferior oblique recession should have corrected her 5 degrees of excyclo. But in retrospect, I was at risk of leaving her on the edge, and I needed to work with an orthoptic team or do the measurements myself to do a more comprehensive exam, and that correcting this small amount of torsion was important for this patient. A second case presented with 9 years of diplopia. She'd been managed with Prism. She looked typically like a sagging eye syndrome with a moderate esotropia in the distance, a small hypertropia, much less ESO at near. She only had 3 degrees of excyclo, and typically we would say, or in the past I would have said, well, this is well within normal and I'll just leave it alone. And indeed, she could fuse with horizontal and vertical prism in space, and so ostensibly torsion was not a barrier to fusion. But when I put her on the synoptophore, what was interesting and the first sign that something wasn't entirely right was that she complained spontaneously that the house targets were tilted even when everything was corrected. And I had to actually induce 5 degrees of excyclo correction on the synoptophore to eliminate the tilt. But that was the start of the story, because as I reduced the amount of cyclo correction, I found that she actually broke into 2 images right at 0. She was right on the edge, and she broke in the other direction at 10 of excyclo. So what that suggested to me is that for her to be comfortable, she needed that excyclo to be corrected. So I did the standard bilateral medial rectus for the ET. I did the standard superior rectus temporal pole recession for the right hypertropia. But I did a resection and an advancement of the anterior 1/3 of the superior oblique to address the excyclo. And at the time of adjustment, she did demonstrate that desired in-cyclo overcorrection in the torsional axis, and so I tied her off at that point. And she did well over time. So what's my take home from this case is that there are patients with sagging eye syndrome that may have torsional problems that need addressing. So you need to listen for history of twisting, and I would advocate assessing torsional amplitudes in these patients. And in this particular patient, 3 degrees of X-cyclo appeared to be problematic. There are alternative approaches to this, and Dr. Hunter has highlighted many of them. And some of you will be doing inferior rectus temporal pole recessions or partial tenotomies to address a patient who has a coexistent torsion. And as Dr. Hunter highlighted, choose your vertical rectus carefully to make sure that you don't make the X-cyclo worse. So my conclusion is that small amounts of cyclodeviation, even 2 or 3 degrees, can be problematic for some patients, and that you need to listen carefully for symptoms of twisting, symptoms of fragile fusion or blur, and I would advocate assessing patients on the Synoptophore if you have that available and work with your orthoptic team. Again, I'd like to encourage you all to consider coming to our International Strabismological Association meeting in November, and thank you for your attention.
Well, thank you very much, Jonathan, and thank you, Rosario and David and Dr. Kushner for hosting this all. Most of the questions have been answered on the chat, but I wanted to raise 2 questions here which came up for our panelists to discuss. One is the difference between fusing a small versus a large target, and how does that affect the outcomes, be it in a Synoptophore or you're testing in the office? And the second that has been asked of me in the past is if you're resecting or advancing, just say the anterior fibers, the anterior third of the superior oblique, are there special techniques you choose, Jonathan or David, I have my own, so that you don't end up with a partial tuck of the rest of the superior oblique? Open the floor to any of our speakers.
If you wish, I can answer. Well, yes,
Sure.
there is a difference. If we use big target, they will fuse better than with smaller ones. So smaller targets will get more amount of fusion, at least in my hands. I don't know if you all agree. And yes, with the fusional target, you don't have the same amount of torsion, and if you do it with a line on a cross. So I think if you want to know how much torsion you have, I prefer to see the lines, and then, as Jonathan said, then I will use the house to see how they can fuse. Maybe can you add something else, Jonathan?
Yeah, no, I agree. To some extent, we're limited within the Synoptophore as to what size targets we can get. There are other systems that provide larger targets, and you're going to get something different. And clearly, the Synoptophore is not the real world, but the house targets for me are as close to the real world as you can get to test, how much torsion you need to correct to promote fusion. Regarding not involving the posterior fibers, over the years I've been taking less of the anterior fibers, and so years ago I used to take half the tendon. I've tried to take less. Once you start getting less than a third, it's a little bit technically challenging to imbricate and to keep your orientation, and to, particularly if you're using an adjustable technique, that you want to be able to move that tendon backwards and forwards. But splitting it for 20 millimeters, I think, is particularly helpful. So how far you split and then taking less than half, I think, are the techniques that I use to not involve the posterior fibers. But I have to say that you do tend to get a little bit of a Brown syndrome no matter how little you take. So that is something. Maybe you take a history from the patient. If they play pool or billiards for money, you might want to avoid that and look at some of the other techniques for addressing torsion that Dr. Hunter highlighted, because you may induce a small Brown-like syndrome despite just taking a third of the tendon.
Yeah, in my own hands, I find that just the more I split it, the less impact taking that anterior third has on the rest of it. So it's not like you just take the anterior third, pull that up, and the rest is unsplit. It's really quite to take that down pretty far.
Yeah, I was splitting. I still split 20 millimeters, even if I only want to do an 8 millimeter resection, for example.
Yeah, and just splitting with this with a little Stevens hook or something, it makes it you're a little more comfortable going back as far as you have to go, as opposed to, say, using scissors.
Yeah, I start with the hooks, but as you get back towards 20, it's not uncommon to find that the hook won't go back any further. And so I don't hesitate I'd rather not stop my split there. So then I very carefully take my Westcotts and looking at both sides of it to make sure you stay in that line. I keep going until I get to 20 millimeters.
My approach as well. Any other thoughts? If not, we'll turn the floor back to Bert.
Well, thank you. Wow, that was just an amazing webinar. Rosario, Jonathan, David, I'd like to really thank you very profoundly for your excellent contributions. And Linda, an amazing named lecture. You have joined your 10 predecessors in giving this named lecture. And as such, you have been presented with the medal. On one side is this engraved likeness, and the other side is the seal of the great University of Wisconsin. So wear it well. And again, I would like to thank
Thank you so
everyone.
much.
And
It's right here.
zipped it through cyberspace.
We'll wear it well.
And by the way, no one has ever gotten COVID while wearing the medal. It's protective. So, and I'd like to thank the audience for tuning in. And I'll turn it back to you, Linda, for final word.
Well, thank you, all of you. It's a Sunday morning. Those of us in New England or even in the central United States are in the middle of a massive snowstorm. Those of us overseas don't know that we're about to be clobbered with 1.5 feet of snow in the next 24 hours. So we're toasty warm and inside, learning about a topic we all love and hold dear. Thank you all again for participating, and for those of us who showed up this morning, for coming on your very precious Sunday morning. Take care. Bye-bye.
Thank you.